The Healthcare Labyrinth Podcast is back for another episode. Join Marc S. Ryan, a veteran health plan and health technology executive, as he explores the world of healthcare.
Welcome, everyone, to this edition of the Healthcare Labyrinth Podcast. My name is Marc Ryan, and thanks to everyone for listening in. As we approach the end of the year, we are going to reflect on healthcare in general and perhaps prospects for any healthcare reform. At least one part of the podcast may shock you as I confess to some evolving views on coverage. We will take our usual 3 breaks today. Let's get right into it. In general, my theme is that crushing costs may mean a relook at comprehensive coverage. Zeke Emanuel, one of the key authors of the Affordable Care Act, had an interesting opinion piece in the Washington Post on December 2nd. He articulates many of the same things I say in my book, The Healthcare Labyrinth, and offers a blueprint in part for lasting reforms. A key recommendation he makes is price reform, one of my 3 tenets of healthcare reform, which also include comprehensive coverage in primary care and care management. On price, Emanuel notes that hospital prices have risen faster than any other sector since 2000. I've made the case that hospitals are entirely unaccountable, and they control more than just emergency rooms, outpatient, and inpatient care. They have taken over at least half of physicians in the country and essentially have gutted independent primary care, and in that course have changed practice patterns to encourage use of high-cost hospital-owned settings. Emanuel is right that site-neutral payments are an answer. He also wants commercial price caps. Commercial rates piggyback on Medicare rates, and employer plans pay exponentially more than Medicare. Plenty of studies show that efficient hospitals can make money on Medicare and Medicaid, and commercial rates that are just slightly higher than Medicare would be okay. The problem, hospitals are among the most powerful lobbies on Capitol Hill and have bought off Democrats and Republican lawmakers alike. Will lawmakers finally realize, though, that it is not nasty insurance companies that are making care unaffordable, but high costs throughout the system, principally driven by hospitals? Emanuel also encourages the following. First, value-based payments. In the physician world, I like partial and global risk arrangements to align providers on reducing costs and improving quality. Second, requiring insurers to offer the same prices for all customers. I have discussed another topic that Emanuel mentions, that insurers essentially charge self-insured employers who are at risk for healthcare more than what they pay providers if the plan is at risk for costs. This is very much hidden from employers. I have argued, like Emanuel, that fixing prices across lines of business, regionally or nationally, would encourage efficiency and reduce commercial costs. Third, Emanuel wants pharmacy benefit manager and drug reform in general. And fourth, he recommends leveraging technology and other reforms to reduce administrative complexity and costs. With that, we will take our first break, and when we come back, we will discuss some encouraging developments on the healthcare reform front. Be right back.
Health plans and insurance are confusing. Our healthcare system is in dire need of reform. Health policy expert Marc Ryan tackles both issues in his book, The Healthcare Labyrinth. It is both a guide to navigating health plans and fixing American health insurance. Marc dives deep into how health plans and the American health insurance system operate. He then outlines a comprehensive reform agenda for the system as a whole, including pricing, emphasizing health and care management, and ensuring affordable access to health coverage and a private delivery model. Marc is a bit of an unconventional Republican in that he believes affordable access is the morally right thing to do, and that it is also fiscally prudent for our nation. Learn more about Marc's book, The Healthcare Labyrinth, at healthcarelabyrinth.com or search at leading bookseller websites. Available in print, ebook, and audiobook forms.
Welcome back. We are covering developments in healthcare reform this week. We are going to cover some of the positive developments we have seen this year so far. All is not dire on the healthcare reform front. Here is some areas where I give a lot of credit to the Trump administration. The president has done a good job of pushing drug price reform down the road. A series of executive orders encourage fulsome reform of the drug channel and on price. While I think President Trump needs to push further and not settle for deals with Big Pharma, those deals begin to reset the table on drug price in America, including reductions here and higher prices in other developed countries. On higher prices in other countries, I was actually amazed that Trump's tariff plan or threat actually gained higher prices in the UK. The second round of Medicare drug price negotiations also netted more than round one under President Biden, perhaps double Biden's 22% net reduction in price. Demands for abandoning rebates and greater transparency also have led to some budding reforms. Interesting, too, is the fact that Trump's concessions on drugs now have brand drug makers ready to sell directly to employer groups at discounted prices. A Trump rule also took yet another baby step on site-neutral payments. The outpatient reimbursement for drug administration services, such as chemotherapy, will be reduced by 60% when provided in off-campus hospital outpatient departments. Earlier, payments were reduced for services provided in relatively new off-campus hospital outpatient departments. That began in 2017, and for clinic visits provided in all other off-campus outpatient departments. That began in 2019. Applying site-neutral policies to all hospital outpatient billing would save at least $157 billion over 10 years. More importantly, huge savings would also occur in the commercial world, as those rates are based on Medicare. In a related move, CMS also is phasing out the inpatient-only list over a 3-year period and expanding the ambulatory surgery center covered procedures list. The Trump administration has also sought to reform the out-of-control 340B program with a pilot. That 340B program does little to control drug prices and has become a slush fund for hospitals. With that, we will take our second break, and when we come back, we will discuss whether it is time to rethink comprehensive coverage. Be right back.
Lilac Software is proud to work with the Healthcare Labyrinth website to educate people on the healthcare system. At Lilac, we believe transparency is so important in healthcare. The healthcare system is opaque, and Lilac is trying to bring clarity to data and unleash the best member care, reduce costs, and improve outcomes. Our cloud-native payer platform revolutionizes data insights and analytics. Plans have all the data they need, but in silos locked away in point solutions. At Lilac, we solve the data fragmentation problem and help plans turn complex data into actionable insights, leading to greater operating leverage, tight cost controls, and healthier members. Health plans can improve STAR scores, reduce medical expense, drive revenue, and more. Quite simply, with Lilac, you can drive better business and health outcomes. Learn more at lilacsoftware.com.
Welcome back. We are covering developments in healthcare reform this week. We are now going to cover whether it is time to rethink what comprehensive coverage is. Most of you know I am a comprehensive insurance guy. I continue to believe sufficiently robust insurance and subsidies to help those in need purchase healthcare is a good idea. But I am beginning to redefine in my mind what comprehensive coverage is, or maybe should be. Why? Because even with the exchanges and expanded Medicaid, our uninsured and underinsured crisis has not waned. Yes, it will increase due to the effects of the One Big Beautiful Bill Act over time. But my issue is the here and now. Price, costs, and premiums have been increasing dramatically, 6% to 9%, if not more annually, putting coverage out of reach for many Americans. Many Americans simply cannot afford premiums in the employer world. Many of those who can pay the premiums cannot afford to use their insurance appropriately. With a family insurance bill hitting almost $27,000 annually now, we have a huge problem. Consider, too, the plight of Medicare beneficiaries, most of whom are on fixed incomes. CMS released its annual updates for traditional Medicare Part A and B premiums, deductibles, and cost sharing. There was a huge surge in Part B premiums monthly by almost 10%. The Social Security cost of living increase was just 2.8%, or about $56 per month on average. The Part B premium increase will eat up $18 of that. Part B is paid 25% by enrollees via premiums and cost sharing, and the government 75%. So the almost 10% hike in Part B premiums shows just how out of control traditional Medicare really is. It is now a $1 trillion plus behemoth and growing dramatically each year, despite huge holes in the benefit and an antiquated traditional fee-for-service component. The price reforms I discussed above would bring the cost of insurance down and make it far more affordable. But in the meantime, do we need to think more broadly about insurance and entertain changes to minimum essential coverage in the ACA? The One Big Beautiful Bill Act did create some pathways to rethinking such coverage over time. Bronze and catastrophic plans on the exchanges are now considered HSA-compatible, high-deductible health plans, allowing enrollees to open and fund HSAs. Direct primary care was also authorized in the One Big Beautiful Bill Act, and is now an eligible HSA expense, and DPCs do not disqualify someone from having an HSA. These and other reforms seem like reasonable ways to get people covered with some insurance or coverage, especially if they cannot afford insurance or afford to use traditional insurance if they have it. These types of products also appeal to a younger generation, which is suspicious of traditional coverage and insurers and prefer individualized care that may be on demand and via technology. With that, we will take our third break, and when we come back, we will discuss a new pilot in traditional Medicare and the president's attack on health plans. Be right back.
The Healthcare Labyrinth is no ordinary website. It features news and commentary from one of the nation's leading healthcare policy and technology experts. Marc Ryan combs the internet for the latest healthcare news and publishes a news feed each weekday with summations and Marc's insights. Twice a week, Marc publishes a blog to go deep into a current issue. And of course, Marc hosts a podcast each week to delve even further. All of this is available at healthcarelabyrinth.com. Visit each day for the latest happenings in healthcare. As well, learn more about Marc's book, The Healthcare Labyrinth, at the website. That's healthcarelabyrinth.com, your go-to source for healthcare news.
Welcome back. We are covering developments in healthcare reform this week. We are now going to discuss the traditional Medicare access model that was just announced. CMS announced a new Medicare fee-for-service pilot to test chronic care management. The Access Advancing Chronic Care with Effective Scalable Solutions model tests an outcome-aligned payment approach in Medicare. The model is aimed at expanding access to new technology-supported care options that help people improve their health and prevent and manage chronic diseases. The model will cover conditions affecting more than 2/3, tens of millions, of people with Medicare, including for heart disease, diabetes, obesity, kidney disease, chronic musculoskeletal pain, and depression. It will run for 10 years beginning July 1, 2026, and will have voluntary enrollment. Traditional Medicare doesn't cover many digital tools, pays only for visits, not outcomes, and has little or no care management. It has barriers to remote monitoring, digital therapeutics, and behavioral support. The technology-supported, proactive, continuous care access model will have payments tied to outcomes rather than just volume. The model allows providers to use any tech-enabled care approach: telehealth, remote patient monitoring, digital therapeutics, care coordination, apps, and devices. Providers get predictable recurring payments. Full payment is earned only when patient outcomes improve. For example, when blood pressure is under control, diabetic hemoglobin A1C tests show improvement, pain is reduced, and depression scores are better. Now, I have been suspicious of the proliferation of traditional Medicare pilots. Most have been unsuccessful, haven't saved, and didn't lead to better quality. For example, even one pilot focused on a disease state was a huge failure. Over 6 years, the much ballyhooed diabetics prevention program enrolled only about 9,000 people out of millions eligible. I have encouraged CMS to collapse the number of pilots out there and focus on just a few. But I think CMS is on to something here. Uncontrolled disease states account for a huge share of spending on healthcare, and this is particularly true in Medicare. A recent study in the Journal of the American Medical Association found that disease states are poorly managed in America. 43% of patients with diabetes and heart disease are not treated at all with evidence-based treatments, and only 20% are treated adequately based on evidence. So, attacking the disease state problem is key, and testing the emerging role of technology to do so is key too. Let's conclude with one last subject. A victim of the affordability debate appears to be health plans. President Trump has turned to attacking health plans in the wake of a concerted effort from Democrats, accusing him and the GOP of not doing enough to tackle affordability. In a recent social media post, Trump directed his ire on affordability on health plans, saying, quote, "The only health care I will support or approve is sending the money directly back to the people, with nothing going to the big, fat, rich insurance companies who have made trillions and ripped off America long enough." End quote. Of course, that is not true. Health plans have been underwater the past few years in terms of margin. They average no more than 5% in good times due to administrative cost and margin caps. Other healthcare entities make far more than health plans. But Trump may have the pulse of the nation here. A recent poll determined 63% of those surveyed say insurance companies were the most responsible for medical debt, and 76% say they want the country to switch to a different health insurance system in which they can be unemployed or self-employed and still remain insured. And 74% in another poll said they were in favor of Congress extending the exchange tax credits rather than letting them expire. But when asked if they should be extended when reminded they were enhanced during the COVID pandemic, support did drop dramatically. With that, we will conclude this edition of the Healthcare Labyrinth Podcast. We'll see you next week. Take care.
Thanks for joining Mark and the Healthcare Labyrinth Podcast. Go to healthcarelabyrinth.com each day for the latest healthcare news. See you next week on the next Healthcare Labyrinth Podcast.